เดอร์สันนะคะก็เรียน IR เรียนนิวโรนะคะแล้วเรียนแอบโดเมน2 ปีหลังจากนั้นก็สอบบอร์ดนะคะเป็น American Board of Radiology แล้วเราก็ได้มาเจอกันนะคะหลังจากที่อาจารย์ตัดสินใจว่าอาจารย์อยากเรียนเชสก็มาเรียนเชสเพิ่มกันที่ IU นะคะสักเกือบ10 ปีแล้วนะคะพี่ต่ายได้ไหมสักเกือบ10 ปีนะคะแล้วหลังจากนั้นอาจารย์ก็ไปเรียน Cardiac Imaging เพิ่มที่บัลติมอร์นะคะตอนนี้อาจารย์practice เป็นทั้งเชสแล้วก็เป็นทั้ง Cardiac Imager นะคะอยู่ที่ University of Emory นะคะวันนี้อาจารย์จะมาพูดถึงในเรื่องของ acute chest pain ใน emergency นะคะว่าเราในฐานะรังสีแพทย์เนี่ยค่ะมันมีอะไรที่เราควรจะต้องรู้บ้างมีเรื่องของเทคนิคอะไรยังไงบ้างนะคะแล้วก็ครั้งนี้เนี่ยอาจารย์ให้เกียรติที่จะพูดเป็นภาษาอังกฤษค่ะเราจะได้ลองดูว่าของเราเนี่ยจะเป็นยังไงบ้างถ้าสมมติเราลองออนไลน์เป็นภาษาอังกฤษนะคะเดี๋ยวขอเชิญอาจารย์พี่ต่ายเลยค่ะพี่ต่ายแชร์สกรีนได้เลยค่ะหรือพี่ต่ายอยากพูดอะไรก่อนนิดหน่อยก็ได้ค่ะเชิญเลยค่ะ
ภาษาอังกฤษไม่ต้องกังวลเลยนะคะภาษาอังกฤษแบบไทยๆอะค่ะที่ได้รับมอบหมายวันนี้นะคะเรื่อง acute chest pain in the ED actually it is in the clinical practice. This includes the emergency department and also the in the clinic. And the approach of the acute chest pain is different from region to region. In European countries, it's different from America. So in the European country, there is 2-3 big guidelines here. Nice guideline. This is the National Institute of Health and Care Excellence was updated in 2016 about the acute chest pain. This is from England. And in that guideline has not recommended the image study for acute chest pain, for acute chest pain at all because they will do cross-sectional imaging to rule out only aortic dissection and PE. Otherwise, they are very confident. They are very confident about their diagnosis of the acute coronary syndrome, just the basic labs and the high sensitivity troponin, and that is enough for them to diagnose. But in the European Society of Cardiology has a guideline for the STEMI and non-STEMI 2017 and 2015. This has a little bit allowance of using coronary CTA in case of equivocal case. So the recommendation is not a firm recommendation. This is different from the United States. In 2019, the American College of Radiology still recommended that the coronary CTA is the investigation, almost like investigation of choice of acute chest pain in the ED. Besides a clinical exam, a physical exam, and history taking, we also look at the pretest probability. There are a few score that we use here. We use Diamond Forrester score, which is the very old score. This score will get the patient into low, intermediate, and high risk probability of for a coronary artery disease. This was invented in 1970, so it's the oldest. And at the moment, we also have Duke's clinical score. Duke also divides the patient into the same category and then the patient prognosis as well. And the last one, the newest one is the CAD consortium score. This is the newest one, was in 2012. So the coronary CTA, when we do in the ED, we do it for a patient who has only low to intermediate probability of a coronary artery disease, which is about 20 to 80%. In the high-risk group, there's no need to do that because most of the time it's certain that the patient will have coronary artery disease. And this is the cause and admission of acute chest. Most of the patients, up to 83%, and only 17% will be admitted in the hospital. In 17%, a quarter of those will be acute coronary syndrome, and another quarter will be angina pectoris and non-ischemic. non-ischemic cardiac problem. Another quarter will be unspecific chest pain, and the last quarter will be non-cardiac cause. Only 2 to 3% will be vascular emergency, such as acute aortic syndrome and pulmonary embolus. Why is it important between these acute the vascular emergency and pulmonary embolus? Because it's life-threatening and it's a treatable condition. So for the acute aortic syndrome, there are 3 categories. It is acute aortic dissection, intramural hematoma, and penetrating aortic ulcer. For PE, it's just a and coronary artery disease is obstructive coronary artery disease that can cause a chest pain, and also tension pneumothorax. We will be able to see that from the too. This study, most of this study will deal with CTA. For CTA technique from head to toe, we have 2 techniques. It's the bolus tracking technique and the test bolus. In bolus tracking technique, we do scout image here. Excuse me. We do scout image and we do tracking the patient here, right here, just below the carotid. And then we'll get, this is an example of how we do a PE protocol here. So we will get that image without contrast first. When the contrast is getting in, we can just see that this is getting in the pulmonary artery and here, and then this is the graph that we get from the scan. We scan the patient the first scan, second scan, and the third scan. When this density hit threshold that we set up, so the scanner will automatically start the patient right away. The threshold is standard threshold is about 120 to 150 Hounsfield units. And this is the test, how we do it. So we do the scout PA and we do lateral, and we use the same tracking right just below the carina, just 1 to 2 centimeter below the carina. And then this is aortic protocol. So we scan first injection, we use 20 cc of the contrast, and then we put the ROI in the ascending aorta, and then the contrast coming in right here and then going down. So we get the curve here. We know exactly where is the peak. And then after that, the second injection will be the real injection. We inject the full dose of contrast, and then we wait until 22 seconds here, and then we scan the patient. So this is the bolus. The question is, which one is better? It doesn't matter. Whatever works for you, that one is the best. And acute aortic syndrome, we have aortic dissection, intramural hematoma, and penetrating aortic ulcer. All these 3 will use the same classification. We normally use Stanford A and B. And we consider that they are the spectrum of disease. They are all related. So it happened here. We have the in the tunica intima, and it causes ulcer, and later on blood going into the tunica media and may going out of the tunica advent. So this is just the spectrum of the disease, all these acute aortic syndrome. So this the Stanford A, and Stanford B. Stanford A, whatever that involve the aortic root in the ascending aorta, and before the origin of the right innominate, origin of the right innominate, that's considered A, and doesn't matter that it's going to involve the descending aorta or not. But Stanford B is the involvement is after the takeoff of the left subclavian artery and go down. Here you can see that there is problem area here. No one talks about aortic arch dissection here. So that's Stanford A. They left out the arch dissection. Okay, this is protocol setting for acute aortic dissection. How we do it? We do scout a lateral from the lung epiphysis to the femoral head here, and then the yellow line here, we scan the patient non-contrast to be able to see intramural hematoma, and then we scan the patient in arterial phase in the blue line here, and then we out from the just below the carina again. So this is protocol setting of acute aortic dissection. Aortic dissection, we talk about just the technique, and then we talk about vascular. Vascular, we have to answer the clinical question: there is or there is no aortic dissection. And also we mentioned about pulmonary artery, and now we go on and on, talk about the chest section, we talk about abdomen and pelvic section, and soft tissue part. And then the impression, answer the clinical question, number one, positive or negative for acute aortic syndrome. And then number two, other clinical relevant extra vascular findings. And then this is our acute aortic, this is a dissection, aortic dissection is one of the acute aortic syndrome. It is the most common type of the acute aortic syndrome, about 3. So we were talking about the spiral course of the intimal flap. And now I'm going to show you a few cases of aortic dissection. So this case is a 45-year-old African-American man with uncontrolled hypertension, excruciating back pain, and left lower extremity pain, numbness, and tingling. Okay, this is his initial scan when he got here. So we start seeing the intimal flap here, involve their innominate. Right, innominate, and see this intimal flap here. And intimal flap is coming out of the aortic root, and the aorta is super big here. And it's also, we can see that the coronary artery is from the false lumen. And now this is the intimal flap. The true lumen is really small, and the flap, if you look at the course of this intimal flap, you're going to see it's moving spiral. Celiac trunk got involved too, SMA too, and a part of, you can see that it's really small, the lumen. And now we are going down into the pelvis. Aortoiliac bifurcation still has extension of the flap here, flap is here. And notice the right common iliac here. Our right common iliac, see, is thrombosed false lumen here. That's why the patient has a problem about left lower extremity pain as well. So normally, when we do surgery in this patient, you can see the flap is still there. Is still there in the cervical branches, partially thrombosed false lumen here. We normally, when we do surgery, we do it at the aortic root here, at the aortic root, and then the rest of them we don't care much. The control, we have the hypertension control at the aortic root very well. So the rest of the disease will be most of the time it will get better over time. Okay, this is the type aortic dissection, has involvement and thrombosed false lumen of the left common iliac. And then this is the type B aortic dissection in 53-year-old man, hypertensive urgency. So the intimal flap is starting after the takeoff of the left subclavian artery, and here is the true lumen. Here is really small. Notice the course of this intimal flap is spiral, is curving, and then it's just going posterior, and then it will move to another side. So this is got involved, SMA got involved. Right renal is from true lumen, left renal got involvement too. So this is an example of type B aortic dissection. And okay, one is intramural hematoma. This is why we need to do non-contrast to be able to see this intramural hematoma better. So it's the second most common cause of acute aortic syndrome. In the past, we used to, our concept is rupture. Vasa vasorum, the vessel that supply the aortic wall. nowadays the concept has changed. They consider all these three, the acute aortic syndrome is the spectrum of the disease. Sometimes we can see intramural hematoma, aortic dissection, and penetrating aortic ulcer, all three in one patient. So how do we see this intramural hematoma? So the blood is in the media here, right here, and sit there. So we see hyperdense smooth margin area in the tunica media. The Houtfield units is the blood, so it's about 40 to 70, and it's not spiral. The cross is straight down. And the size of the aorta itself and the thickness of intramural hematoma have a clinical implication and can tell that the patient will do a good or bad in the clinical course. And the most important thing of the intramural hematoma is ulcer-like projection and intramural blood pool. These two look alike. So we to differentiate these two. Why? Because ulcer-like projection tell us that the patient will do bad in his clinical course, but intramural blood pool has nothing to do with the clinical course at all. And then this is the 77 years old ischemic heart disease patient, recent CABG, presented with chest pain. Okay, this is non-contrast. It's a bit dark because I want want you to see the intramural hematoma. So we start seeing some dense rim of the ascending aorta here is big and have hyperdense rim here, and also here too. And let's look at this same person on contrast or arterial phase here. So in the arterial phase, all of these are intramural hematoma, and you can see there is intramural hematoma, and there's a funny thing right here at the ascending thoracic aorta. All of these are intramural hematoma. If we don't do non-contrast, we may not be able to see this. And okay, we show you. Funny thing that we talk about here, this guy, is this ulcer-like projection. So we can tell that this is intramural hematoma and start having ulcer-like projection here. So this patient is not going to do any good in the course with ulcer-like projection. Actually, it's not. There's some confusion between ulcer-like projection and penetrating aortic ulcer. We'll talk about that when we talk about penetrating aortic ulcer. The next case is 70 years old man with chest pain. So this is a non-contrast. Want to show you this is bright density, high density here. This looks fine. Ascending look fine. Only this descending aorta here has a little bit of a bright wall. And then this is the same patient with contrast arterial phase. You can see this is the intramural hematoma. Doesn't look so bad, right? Doesn't look so bad at all. Just a little bit of intramural hematoma. So this is considered type B because it's the origin is after the takeoff of the left subclavian artery. The treatment is the same as the aortic dissection. And same patient, look at this, 3 months later. 3 months later, from that intramural hematoma, now we start seeing something that is bulging out here and has this outpouching of the contrast into the big intramural hematoma. And this is when we do reconstruction, the ulcer-like projection. It's really tricky intramural hematoma because sometimes it's resolved by itself. Sometimes it's progressed into ulcer-like projection and has dissection later. It's like really unpredictable. And this is another one of the type B intramural hematoma has focal dissection and have a ULP, ulcer-like projection. So this is our intramural hematoma here. Okay, just follow me down here. So this is, we start seeing ulcer-like projection. and intimal flap. This is almost like focal dissection. And person has intramural hematoma, has a penetrating like ulcer, and has a focal dissection, and this another focal dissection here. So they all are in the same patient. Okay, next one is the penetrating aortic ulcer. This is a disruption of elastic lamina with varying degrees of extension through the layers of the aorta. And PAU itself may lead to the intramural hematoma, pseudoaneurysm formation, and transmural rupture if they extend through the adventitia. And we call is exactly the same like outpouching of the contrast, like penetrating like ulcer, but penetrating like ulcer occurs in the intramural hematoma. Penetrating aortic ulcer occur in atherosclerotic vessel, especially descending thoracic aorta. We're going to see a CT of a few patients here. So this patient, 53 years old female with abdominal pain and chest pain. This is the arterial face, 3 vessel arch. And we are going down, follow this. It has a little bit of atherosclerotic disease here, a little bit of atherosclerotic disease here. Okay, now, this is the penetrating aortic ulcer. And we can look at that here. Normally, intramural hematoma, you're not going to see it only one location. You see it like all contiguous from here to here. But this is just projected very focal bulging here. This is the magnified view of the same lesion. So this is a penetrating aortic ulcer. Type B. Okay, now we talk about PE protocol, how we do it. So we scan the patient, we do a scout, and then we scan the patient just below the carina. And we got one, this is the bolus tracking. We got the first scan, no contrast. The second scan, the patient breathing a little bit. So we're missing part of the main pulmonary artery. And then the third scan, we got it back here. And the fourth scan, here. So we scan the patient 4 times. Look at the curve, 1, 2, 3, 4. We set the threshold at 100. After the contrast is reaches the 100 Hounsfield unit, the scanner will start scanning automatically. So this is the bolus tracking. 80 years old man with shortness of breath. This is his CT. PE protocol. Okay, we see obviously the patient has the pulmonary embolus here. It's in the distal left main and distal right main, involved lobar segmental and subsegmental. Some are occlusive, some are non-occlusive. But you can see that the patient, the heart is a bit funny here. So when PE, we normally do measurement of the main PA to see it's big or not. If it's big, it's pulmonary hypertension from PE, maybe from acute PE or chronic PE or other types of cause of, there are 5 causes of pulmonary hypertension. So this is 2.8 is normal. Less than 3, consider normal. More than 3, consider big. And then we measure on the images, you go to the level that you can see the biggest cavity of the left ventricle, and then measure it, and then go to the same, not the same image, because the heart axis is a little bit tilted, so you're not going to get the same diameter. Biggest diameter of the right and the left will be different slide. So this is the right, is the right ventricle is 6, and left ventricle is 3. And I also did the reconstruction on the cardiac. This is short axis view. Want to show you that how the septum, interventricular septum, has strengthening like this, right? And normally the pressure in the right heart, it is less than the pressure in the left heart. So the septum, either in diastole or systole, it should be bulging toward the right ventricle. But in this case, the septum is strengthening. It means that the pressure in the right heart is just so much, so it push away the septum to the left. And this also show you how big the right heart is. Normally, the right heart should not be bigger than the left heart. And also look for the pulmonary infarction here. People has been using dual energy for PE. There's some use of it, but for me, it doesn't help much if we have a good contrast enhancement at the beginning. For example, for this case, 54 years old man with tachycardia. We use dual energy here. This is our routine protocol. We use 30%. This is a hybrid between low energy and high energy. 30% of low energy and 70% of the high energy. We measure the density in the pulmonary artery. It is about 324 Hounsfield unit. And look at this. This is at the lower energy. It's 50 keV. So the contrast enhancement is double. So it's around 677. And then look at the low energy. We have almost the same enhancement of the contrast, 348, and our hybrid or the usual is the 324. So if we have the good contrast enhancement at the beginning, seems like the low energy image help, because we already did it at the beginning, so there's no need to look at these low but if we do not get a good enhancement, suppose we get this is for 200 and then it's not diagnostic. 200 is too low, it's suboptimal enhancement. So if we have low energy, from 200 will become 400. So 400 from non-diagnostic study become diagnostic study. That's how the dual energy will help us for the PE. And this is the same patient. So this is the dual energy CT. We can see that the patient has a little bit of embolus here. Right here in the lung basis. So we measure the density, not the density, the diameter of the main pulmonary artery. It is 2.9, still considered normal. And then we measure the biggest diameter of the left ventricle, and biggest diameter of the right ventricle is almost the same. And then I also did the reconstruction on the short axis of the cardiac axis. We can see that the septum is not bulging toward the left ventricle, so there's no right heart strain here. And then this is the grayscale image of the pulmonary blood volume. So it can tell you where the in the pulmonary artery goes here. Okay, this is a grayscale. It's from GE scanner, so the images is not so lovely. Let's look at the Siemens scanner. We have a better pulmonary blood volume images here. So color coding here. Where the blood goes or the eye go, you will see the yellow, sorry, the orange color here, or this is on the coronal, and this is from axial. You can see that this is the blood is going, but there's no blood here because there is atelectasis. So there's also some pitfall of this. Sometimes it helps you to detect pulmonary infarction. Sometimes you have the wedge-shaped area in the periphery of the lung, make you have to look back at your scan. Is there any more PE in that area? This is the pulmonary vessel extraction. You see only the pulmonary vessel. It's just a fancy images. For me, it's not useful. The report of the PE protocol, we talk about the quality of the image, the enhancement, excellent, adequate, or suboptimal contrast enhancement artery is limited by what? By motion artifact, by image noise, and overall examination. Is it good? Is it fair? Or is it poor? This will tell the clinicians that how confident we are in interpreting this study. And the impression, we have to answer the clinical question, no or yes or no. Our job, our radiologist job is to say segmental, at least segmental pulmonary embolus. The patient have or do not have segmental pulmonary embolus. Acute subsegmental pulmonary embolus is the must that the clinician will treat the patient. If it subsegmental, there may be two options. They may treat the patient or they may not treat the patient. The patient has a subsegmental PE, but it is a walk-in patient. The patient is healthy. They don't treat the patient. If the patient has subsegmental PE and stay in the is in the ICU, they will treat that patient because it's a high-risk patient. And when in the impression, I normally say occlusive or non-occlusive PE. What level is that? And then is the patient had pulmonary infarction or not, and right heart strain or not, and measure the RV to LV ratio, how big it is, and the main pulmonary artery, how big it is. All of this, only one thing that has clinical impact is the RV to LV ratio. If it's more than 2 to 1, it's considered bad. The last topic is about acute coronary syndrome. Now we're talking about non-STEMI, unstable angina, and STEMI. So the indication for a coronary CTA, if the ECG negative or indeterminate, patient is low to intermediate pretest likelihood. Beside all of those scores that I told you about, the cardiologists like to use TIMI score and use heart score as well. And it is equivocal of testing in the previous 6 months. But we're going to pass this relative and absolute contraindication for coronary. So how we do it? Sorry. Okay, so we normally scan the patient from the lung, not from epiphysis, actually from the border of this aortic arch and down to cover the diaphragm, or we just have to guess where the heart will go, where the base of the heart will go. And then the same tracking, excuse me. The same tracking area here, I don't know what's going on here. The same tracking area here, so we use the ascending or descending aorta. People try to use descending aorta because they want to avoid the contrast from the SVC that can cause streak artifact in the ascending aorta here. And we normally do prospective getting, and we get the patient from 30% to 80% of the RR interval. And this is an example of the coronary CTA. Get that CTA here. We can see that there's no cardiac motion at the aortic root. A little bit slow now. We'll make sure that we cover the aortic root and we see the origin of the right coronary artery and left main. This is our left main is here, going up. Going down, up here, ramus here, and then circ is here. This is our LAD, and this is our RCA. So make sure that you get every part of the heart. Don't miss the lung base. Once I was a fellow, I did, and I missed the distal RCA. So since then, I go a little bit lower to cover everything, especially RCA. You may miss that. And this is an example of a 53-year-old man with chest pain. So this is the same patient. So we do reconstruction. This is automatic reconstruction from the TerraRecon software. You can tweak this bar down to see how the vessel and the lumen is look like. So you can do that. And this is our RCA, and then this is our RCA here. And then we have one more. This you can look at the diameter. By using this software, measure the diameter RCA. This is the LED, nice and clean here, and this is the circ, it's nice and clean. So when we report this, the coronary CTA, we always talk about CAT-RAT. We have CAT-RAT is the reporting system 0 to 5 and recommendation. This person has no coronary artery disease, no calcified plaque, nothing. So his CAT-RAT is 0. And where it's coming from? CAT-RAT is from this article. It's from consensus from many experts, from SCCT, from ACR, from NASCI, and from college, American College of Cardiology. So you can look this up. It was published in 2016. Until now. And besides by doing those get a study, you can also we can also look at the aortic here and see how nice is the aortic annulus here. We can do the measurement, and this is the aortic sinus. You can see how this is our side, our right, left, and non here, and then we do it from two planes. Get the measurement of the aortic sinus, and then we can do sinotubular junction here too. Beside that, to measure the we also measure it at the ascending, descending, and at the aortic hiatus here, and this also at the aortic arch, and then proximal descending aorta is like the standard measurement of the aorta. And then this is the how we measure the chambers, the size of the cardiac chamber. This is pretty useful for the coronary CTA. You can see everything almost pretty much. And this is the aortic valve, has calcification, has aortic stenosis here, very thick aortic. We also have a peak of the mitral valve here too. This is coronary artery disease. This is from different patients. I just want to show you that how much the CTA can do. And the second patient is 45 years old, female with is a very good case. Substernal chest pain associated with activity and shortness of breath for 2 weeks. Okay, got in her troponin is leaking. So at the time we go ahead and do prospective coronary CTA here. I'm going to bring you to the disease vessel. Look at the LAD. This is not LAD, this is diagonal. This is our LADs here. I'm going to go back and then look at LAD again. LAD with me, follow it, follow it, follow it. It's gone, and then it's coming back. So the LAD seems like it's disappear for maybe like 1 centimeter or less than 2 centimeters. And is up here again, is right here, is the LAD. And if you make an observation, you can see that there is a perfusion defect in the left ventricular apex too. And then look at that. This is the perfusion defect. So something is really wrong for the LAD because this is the LAD distribution. And the patient got cardiac cath. So this is cardiac cath, and this is the left main. Something just not right, and we're going to focus on the LAD. This is the LAD focus here. I'm going to stop. Okay, can see this part has a problem. It's really cut off, and then it has the reconstitution into the distal part of the LAD. So I'm going to play it again. See, there's the patient went on to do intravascular ultrasound, and they see hematoma in the LAD. So this patient, this is the disease problem here, the LAD, the mid LAD. This is diagonal branches here. And then cardiac cath, and then mid LAD centimeter, narrowing, very narrowing with the constitution. It is coronary artery dissection. So a young female come in with chest pain, think about coronary dissection and look for something else like a Marfan or a FMD. But this person does not have underlying vascular disease. The patient eventually stent, cardiac stent later, and there are miscellaneous causes of the acute chest pain, pericarditis, pericardial fat necrosis, gastritis, GERD, or even pneumonia can cause chest pain. I'll show you a few examples here. This person has pericarditis here, very thick pericardium and enhancing. It was a case that I did, when the patient got in here, we have nothing. Patient heart rate was 70 something, and it was too high to do coronary CTA. So I give him metoprolol until the heart rate is like up. And then we did the coronary CTA. The patient got out from the scanner and got fainted because his heart rate is so low. Because he has this pericarditis and has pericardial fluid here, he need to compensate. His body is compensating this pericarditis by having tachycardia, but I lower his heart rate down without knowing that he has this fluid in his heart. So that's why he got fainted. And then the second case, the patient got here because of the chest pain, and we did this to rule out pulmonary embolus. We don't see pulmonary embolus. There's no PE, but there's here. This is pericardial fat and has here, right here. Is this the same mechanism? If people appendicitis in the belly is the same, got torsion of the pericardial fat as the information. Pericardial fat neck. If the clinician doesn't know what they're looking for, they will tell, can we rule coronary artery disease? Can we rule out PE? We rule out aortic dissection? Yes, we can, but the result may not be so good. We call those triple rule out. Have to multi-detector CT. We have to use multi-detector CT. And the problem is not popular anymore. It used to be popular in around 2008, 2009, 2010, and then it disappeared from many places. Even Emory don't do that anymore. So the problem the limitation this is about this triple rule out is because the peak enhancement of the aorta and pulmonary artery is about 10 to 15 second difference. So you're not going to get a good look of aorta if you get a good look of pulmonary artery, and you will not get a good look of pulmonary artery if you get a good look of. Best thing to do, ask the clinician, what are they looking for? Are they looking for PE, or are they looking for aorta or coronary artery? That would be best. If possible, do not do a triple rule out. It's just too much hassle here. I think that is all I have for today. This is the reference that make this talk from. Kenya?
Thank you so much for very excellent talk and very informative. So your lecture is not benefit only for Thai people, because right now on the Facebook Live we have the audience from Myanmar and Bhutan looking listen to your lectures. So thank you so much, Pitai. So I have a couple of questions. So you mentioned about dual energy and spectral CT, and you say when you have a good contrast tracking, you get a good image quality, so you don't need a dual energy. But when you don't have that a good tracking or bolus tracking things, dual energy or spectral CT help on that part, right? Can you hear me? Your computer is frozen again. Hello ได้ยินไหมคะพี่ต่าย Hello มีปัญหาเทคนิคอลอีกแล้วเดี๋ยวสักครู่นะคะระหว่างนี้นะคะถ้าสมมติท่านใดมีคำถามหรือว่ามีประสบการณ์ที่อยากจะแชร์นะคะสามารถพิมพ์เข้ามาได้นะคะหรือว่ายกมือก็ได้ค่ะถ้าสวยอยู่ในซูมเนี่ยยกมือได้นะคะจะได้มาคุยกันค่ะเนี่ยนะคะสงสัยเดี๋ยวเข้ามาใหม่ระหว่างนี้นะคะเดี๋ยวขอประชาสัมพันธ์นะคะพี่ต่ายกลับมาแล้ว ได้ยินไหมคะพี่ต่าย
ยินค่ะ
ได้ยินนะคะมีคำถามค่ะพี่ต่ายตอบเป็นภาษาอังกฤษก็ได้นะคะเพราะว่ามีออเดียนจากภูฐานแล้วก็พม่านะคะคือ you mentioned about like a dual energy and spectroscopy for like with the PE protocol and you say like when you have like a good bolus tracking you don't need that things but when you don't have like a good bolus tracking you need like that like a dual energy and spectroscopy will help with the image quality. So I think like right now for the technology, we switch to like a dual energy and spectroscopy. Do you recommend to have like every patient in the hospital who have like a dual energy and spectroscopy to do the study on that like a protocol?
Right now we start doing it here, but not every cases. Most of the time we will get a good enhancement. For me, it helps just a little bit in case of we did not get a good study. Therefore, if the technology is really good, you always get a good study. You will always get a good enhancement, except the patient, cardiac output is just so low, and that one you cannot predict. That one may be able to help. Don't forget, even if you have good enhancement, doesn't mean that you will have a good study. There's a lot of factors that involve in the image quality, the rate of injection, the concentration of the iodine, especially the motion. The cardiac motion, you cannot fix it. Respiratory motion, you have to coach the patient before you scan, and then we cannot fix. Most of the time, it's not about the contrast enhancement. It's about all of this that lower the image quality, like especially the patient motion. And here, the patient has never listened to us. They move, they want to.
Okay. No, but I mean like a dual energy and spectroscopy help with the contrast volume.
Yes.
Because you can lower the contrast volume maybe like 50% of the normal volume that you give.
People say that, but brave to do that yet.
So you mean like you need more like a research or practice on that part to confirm on that the volume that you can reduce on how much you can reduce, right?
Yes, I think so. At the moment, we still use the same amount.
Yeah. So another question. Okay. So next question is about like a coronary CTA that you mentioned, like when patient come to the hospital with like a STEMI or non-ST elevated MI, and like they get the cardiac CTA, right? So I'm not sure like how often you get that things, because like I think, as I remember correctly, in Thailand, when patient come to the ED with the chest pain, they have like a positive cardiac enzyme. Most of the time, the cardiologist take the patient to the cardiac catheter and do like the cardiac catheterization and like a plasty or like a stent or something. So it's not that often that we get the patient with a CTA coronary emergency.
Yes, often. When I'm on the hospital, I'll get every time that I'm on the county hospital. At Emory, emergency department, so sometimes they will read it, so it won't come across to the chest section. Sometimes we read it for them, sometimes they read it by themselves, so we don't know about the volume here. But at the county hospital, whenever I am on, there will be like one or two every time.
So which means like they choose to do like a cardiac CTA before like the real angiogram.
Yes, this is from the cardiologist here. I used to have discussion with them like, you already have high sensitivity troponin. Why you cares about this coronary CTA? No, we want to be sure.
Okay. So it means it depends between like a cardiologist who practice and decide to like a cardiac CTA or like the real angiogram.
Yes,
Right.
they most of them will prefer to do a coronary CTA first, and just talk to them, read a few of them, and they say that we still use a lot in the United States, not like in European countries. They don't use much like us. Yeah, and I think it depends on
I
the
see.
practice.
Yeah. So I think like a lot of. I see. Yeah. So I think like a lot of when we want to get like a good image quality, it depends a lot on like the technologies to help us like get the good image quality and those stuff. What, right? So I mean like what is like the teaching point for the technologies? What should they know? Or any like the things that okay, this is you need to keep in mind when you have the patient for acute chest pain to the ED. This is like your checklist. And this is like the thing that you should know and like you should like alert or tell us what happened or like the protocol or technique. Mm-hmm.
The thing is, whenever there is a case, I am always at the scanner and scan with them.
Mm-hmm.
I never have let any case pass my eyes. So if I'm on, I will be there. I will tell them what to do. So like a tracking, I want ascending or descending aorta. Where do I need it, and how high is the density, like the heart field unit, and I want it. And sometimes we look at the images and we have to disable the automatic scan and look at it like by eyes, and then look at how, because sometimes the cardiac output is just so slow. If you scan, you're not going to get a good enhancement in the coronary artery. So we have to use our eyes, disable the mode, and then it really depends on the experience of the technologist. Luckily, we have a good one here. So I always there. I am always there. So I have never had any problem. And what is the
okay? So
the technologies? Let me think. I think the decision to make like like I told you that we set up the threshold at 120 to 150, not always true. Because if your scanner is really good and fast, like the Siemens, this Force, dual energy, third generation, that just came out in 2016, the scan is just so fast, you can do it at 100. It depends on the scanner too. So I think the technologist has to know that scanner. And doing the cardiac CT has to be at least 64. The more is
64 slices CT.
At least. More is the better. Yeah,
64 slices. Mm-hmm.
Yes.
So what information that technologists should know before scan the patient in case, I mean like because in Thailand sometimes maybe they don't have like the radiologist sit next to them. What is like maybe like a basic knowledge 101, something that maybe they should know about this thing before, or like they should call.
Yeah, some technologies is really experienced, but some are not. So they have like they should have checklists like we do, because we have to prep the patient. We have to give them beta blocker. We have to give them nitroglycerin. Make sure that there's no contraindication for that. The patient has caffeine, Viagra, sildenafil, or Cialis. All of those vasodilator have to be off. So make sure that the patient got off those medication list before. And like Viagra and sildenafil is short acting, so it's just 24 hours is okay. But the Cialis should be like 2-3 days because the acting is longer. Is long acting, and emphasize normally they get a good scan. I have to go in and talk to the patient directly that what they will experience as a scanner, and I will scare them by saying that don't move, how small coronary artery is, and show them the IV line is smaller than this. If you move just a bit, I can't see things, and it's going to be a useless study. So don't move. What happened? Don't move. And they all stand still. And my study is always good.
Because you scare the patient first.
Right. I do that.
Okay, maybe a good idea to start talking to the patient and see how important of why we ask them to keep still. Yeah. So last question, Pitai. Last question. I think this is stuck in my mind since I was a resident. When you do the study, I usually get the questions get asked by technologies so do you want to do a cardiac gated or not for PE or for aortic dissection?
Okay, so the PE, the answer is no gating, but aortic dissection, if you ask the clinician, okay, which part of the aorta, ascending or descending aorta, they will say, I don't know. So in that case, I think it's worth to do prospective gating because dose is not a lot. If they really have no idea what are they looking for, and in that case, if we see we will see aortic root very clear, so we can rule out the type A dissection. Sometimes the aortic root is the movement from the heart is just so much, and you can't see, and you're gonna say cannot rule out type dissection at the aortic root. It doesn't make sense because they send the patient to do aortic dissection, but to rule out aortic dissection, and we answer them cannot rule out a dissection from the aortic root, and
unacceptable.
Yeah, not acceptable for me. If you're not sure, just do get it. Okay. The dose is not terrible. If I'm a patient, give me a big dose of radiation. Give me the right answer. I don't mind to get a lot of radiation. Just give me the answer. That's what I think. And I think almost everyone will think the same. They have the same idea too.
I think so. And next question is when you give the contrast to the patient, which side do we need to inject, right or left? Does it matter?
It does not matter, except those patients who has the breast cancer. We try to avoid the site that they have disease, or the patient who has the dialysis, the AV fistula, we avoid that. But if the normal patient has nothing in the arms or no surgery, anything we do, but has to be anti-cubital fossa, no hands. And actually should be at least get 18 gauge needle. 20 is okay. If possible, use 18. Because the pressure
the big one
inject is so high, so you inject at least 4. If it's better if you're gonna increase it to 5. For Thai people, they're small. Asian are small. You can use it 4 or 5 at the most. But the Western, the Caucasian, they're big, so you can use up to 6. Sometimes they're so big, we have to use the higher injection rate.
So which means you recommend an anti-cubital. It has to be anti-cubital and big needle. So 18. So on the maybe a 20 to 18. If you cannot get 18, so 20 is okay.
Yes, 20 is okay. But the injection rate should be down a little bit, just 4. Less than 4, you're not gonna get a CTA. And the contrast that you use should be at least 350 iodide concentration. 300 may not give a good. There is a paper from I think the chairman of University of Pittsburgh some years ago. He's talked about the factor that affect the enhancement in the artery in the CTA, and one factor is the iodide concentration and the amount of the iodine and the amount of the contrast and the injection rate. All affect the good quality or not good quality.
Thank you so much ขอบพระคุณมากๆเลยค่ะพี่ต่ายนะคะเดี๋ยวขอดูคอมเมนต์นิดนึงนะคะใน Facebook จากภูฐานนะคะ The comment from Bhutan really enjoy your presentation and it's really helpful. Thank you so much. ค่ะ
Thank you.
from ภูฐานค่ะก็เดี๋ยวนะคะของเราไม่มีแล้วนะคะขอบพระคุณมากเลยค่ะพี่ต่ายมีอะไรอยากฝากอยากแนะนำอะไรอีกไหมคะภาษาไทยได้ค่ะนิส เราหรือว่ามีคอมเมนต์มีอะไรอยากพูดไหมคะฝากสุดท้ายความปิดรายการ
ไม่มีอะค่ะตาล
ค่ะก็ขอบพระคุณพี่ต่ายมากๆเลยนะคะอาจารย์ศิลนาถเทอร์เพนนิงนะคะจาก University of Emory นะคะก็หลังจากจบเซสชันนี้นะคะก็จะมีการส่งใบประเมินให้ทุกท่านนะคะให้ complete evaluation นะคะภายในวันพฤหัสตอนเที่ยงคืนนะคะเพื่อที่วันศุกร์ตอนเช้าจะได้รับใบ certificate แล้วก็ได้รับคะแนน CME 1 เครดิตนะคะแล้วก็อันนี้เป็นเซสชันสุดท้ายนะคะของโมดูล1ของเราอะนะคะแล้วเดี๋ยวอาทิตย์หน้าจะขึ้นเป็นโมดูล2ซึ่งเราจะเป็นโฟกัสแล้วค่ะว่าแต่ละ subspecialty อาทิตย์หน้าเราจะเริ่มด้วย head and neck นะคะก็ต้องเริ่มลงทะเบียนใหม่ค่ะเราจะลงทะเบียนทีละ1โมดูลนะคะลงทะเบียนครั้งหนึ่งในโมดูลนั้นสามารถดูได้ทุกอีพิโซดนะคะเพราะฉะนั้นหลังเที่ยงวันนี้นะคะจะสามารถลงทะเบียนสำหรับโมดูล2ได้นะคะให้คลิกเข้าไปได้เป็นเรื่องของ head and neck นะคะแล้วก็อย่าลืมในเรื่องของการทำ evaluation นะคะก็ยังไงขอบพระคุณทุกท่านมากนะคะวันนี้มีปัญหาทางเทคนิคนิดหน่อยนะคะทำให้มีตะกุกตะกักนะคะก็ขออภัยด้วยนะคะก็มือใหม่หัดเลคเชอร์มือใหม่หัดออนไลน์กันทุกท่านนะคะขอบพระคุณมากๆค่ะขอบพระคุณค่ะพี่ตายสวัสดีค่ะสวัสดีทุกท่านค่ะบ๊ายบายค่ะ